Okay, we're going to continue on with our talks of hepatitis, and then we'll move into the endocrinology section. So, with hepatitis, there's three main varieties we'll run into, or the three main ones you guys are going to probably see most often. There are other varieties, right? But what are the three main ones you're going to deal with? ABCs, right? Easy as 1, 2, 3. You'll deal with all those. So there's not a ton of therapies for hepatitis A. For the most part, you're going to see that it's pretty self-limiting for the most part. How do most people end up getting Hep A? Fecal-oral route, right? So what's the best ways we can prevent Hep A?
Wash your hands.
Clean water, wash your hands, right? So there's some places that'll be a lot more kind of endemic with hepatitis A, but washing your hands really well, make sure you have clean water sources, make sure you have clean food, things like that are all going to be really important to prevent spread of hepatitis in the first place. So how do we don't really have any good treatments for it, so how do we end up preventing it? Vaccines. Well, you'll see that's going to be kind of the main preventative thing that we'll end up using, especially for children, because children, what do they like to do with their hands? Put them on everything and then put it right into their mouths, right? So I'm experiencing that right now. Everything ends up in their mouth, whether it be twigs, whether it be dirt, whether it be, we probably shouldn't let her play as much in the dirt, but it builds up a good immunity, right? So hopefully she won't get Hep A. I don't think so. But anywho, you're going to see that most individuals will self-resolve from this. Okay, so the majority of people in about 2 months or so, they're going to get over it, but in 6 months, most people should have cleared this. This will not be the case for, especially like Hep C, as we'll see, the patients have a lot kind of lower chance for really kind of clearing that infection on their own. Obviously, the goal here is to make sure we can kind of reduce any complications of infection. So what are those kind of complications, do you think? Of hepatitis A. Your liver failure, you see some like diarrhea. What else is like the liver really responsible for as far as? Well, yeah. So you're going to see LFTs, right? So LFTs are. Do you know what you call when your LFTs start to rise? Transaminitis. Which actually that phrase doesn't really make sense. Like you have an inflamed transaminase. Like that's one of those weird words that doesn't make sense. But anywho, so you have transaminitis, which you have elevated AST, ALT. But what's another good way to tell to kind of so you see bilirubin go up, you're going to see jaundice. What's another really good way to tell the actual function of the liver? Because your liver function tests only tell you if really damage is happening to the liver. They're not really good at telling you the actual function. No. You may see some drugs not get metabolized quite as No, not. So as far as the clotting cascade goes, what is the liver responsible for?
Making all of them.
Well, it makes a lot of them, so like 2, 7, 9, 10, like all those ones that things like warfarin inhibit, because remember warfarin works against vitamin K epoxide reductase right there in the liver. So if you have poor liver function and you're not producing those clotting factors, what gets influenced by that? What lab test can you measure? Your coag panel, specifically, what can you measure? PTINR, right? So go back to your warfarin talk, right? So warfarin is basically kind of inducing this limited function of the liver. Same thing happens for anything damaging the liver. So, for instance, if I have a patient who overdoses on acetaminophen, and you guys know the main toxicity with acetaminophen is hepatotoxicity. One of the big things I'm going to check, especially if they come in, they're already jaundiced and they're really presenting, I'm going to check their LFTs, but those are probably already going to be high, but I'll also check PTINR. That's going to be the ultimate kind of test to tell me how well the liver is actually functioning. Because some patients, you're going to find they get really severe, like their LFTs will actually be low, right? They'll actually start to decline again because the liver has no more LFTs to really release, right? But the PTINR keeps increasing, then I know things are going really bad really quick. Okay, so that's the one thing you want to check for. So vaccine is probably going to be the best form for prevention. So there's a couple of varieties. I'm not going to make you memorize the brand names for the vaccines. Just be aware that there are some that are available. But it's important to remember which ones have vaccines available, which ones don't, right? So do you guys know which forms of hepatitis have vaccines? A, B, not C. That's the trick, right? So you got to remember that Hep C does not have a vaccine against it, right? So that's why it's so important that we make sure we get good treatment for that, or prevention is going to be the biggest thing. So HAVRIX, VAQTA, those are all going to be ones that patients, especially children, when they get around 12 months of age, they can get a vaccine against that, and so hopefully prevent infection from the first part. But prevention is the main thing we're going to be seeing with hepatitis. For really severe patients who have a really bad immunosuppression and they can't really mount a response to that infection, sometimes you'll end up giving immunoglobulin. Right, so I haven't really talked about immunoglobulin previously, but basically if you take a whole bunch of people's blood and you were to spin down their plasma, you basically have the IgG left over, right? That's immunoglobulin, and you can actually have that product administered to kind of mount the patient's immune response for them. Okay, so it kind of helps take over for that. So sometimes you'll see immunoglobulin being given especially if they have like post-exposure prophylaxis for like really high-risk patients who may have been exposed to Hep A and they've not been previously vaccinated. But for the most part, most patients don't really need this. They can get over it themselves if they're otherwise healthy. Okay. Looking at hepatitis B, this one is also very highly infectious. It's about 50 to 100 times more infectious than HIV, so very easy for this one to spread. And then you can also see that patients who have kind of a chronic infection, even if they're being kind of relatively asymptomatic, can be a big reservoir for kind of this transmission and spread of it. And it can lead to things like cirrhosis, it can lead to hepatocellular carcinoma, so all kinds of bad things. And obviously the other big thing we worry about is because this can be spread sexually, it can be spread through parenteral transmission, which is, what do I mean by parenteral transmission? Yep. Sharing needles between drug abusers, things like that, or perinatally, so your mom giving it to child. So one of the things that you'll actually be measuring for when you're looking at hepatitis B, I'm not going to get super in depth on doing like blood titers for antigens and antibodies and things like that. You guys will cover that in other classes. But just be aware that we end up seeing that a lot of patients end up catching it from the perinatal spread, right? So mom has never been vaccinated against it. She has infection, and child ends up getting it transmitted at birth, right? So this is why this is one of the big ones that we end up having very early vaccinations for in the NICU. Yeah, so if you have kids that are just being born, like very frequently, that'll be one of the first vaccines they're going to get is Hep B. Okay, so this is actually one of the first vaccines that we had that prevented against a major human cancer. So it's a pretty big deal. You guys think of any other cancers that are prevented by vaccines? Yeah, Gardasil prevents what? Well, it prevents HPV, human papillomavirus, but that prevents what type of cancer? Cervical cancer, right? So that's another one that can potentially prevent cancer. You may see some people will also use immunoglobulin to help use as prophylaxis, but for the most part, people don't need this. They can utilize, they can utilize it as a vaccines for the most part to prevent this. So Recombivax, Engerix-Bº, lots of different varieties that are out there. Some of them are combination products, so we can get multiple vaccines in one. But again, just be aware that there is a vaccine. I'm not going to ask you to remember specifically what brand name goes with which hepatitis, right? That'd be kind of mean to me. But if you have something like TWINRIX, that actually has both Hep B and Hep A at the same time. How come do you think you have to immunize multiple times with the Hep B vaccine, especially in children?
Because of the combination with they're still developing their immune system.
Yeah, so kids have the developing immune system, right? So especially with the first dose, they may not really get full immunity to that. That's why you end up seeing a lot of vaccines that requiring multiple doses in order to help kind of re-challenge the immune system to help develop that full immunity, right? So that's why you end up seeing things being given at, say, like, day 0, month 2, month 6, or whatever it happens to be. It's just to re-challenge the immune system to get a more durable kind of vaccine response, right? Okay, so again, vaccine response in general is just low for Hep B, and so it's again 3 doses offer the kind of maximal protection. So with Hep B, if you were to actually acquire the main goals of therapy we like to have are to kind of maintain good viral suppression, right? So keep the virus from replicating as much as possible, and we'd like to have the seroconversion to having anti-hepatitis B, this envelope antigen, right? I'm not going to get super in depth on lab tests and things like that, but basically you'd like to have antibodies against the Hep B, right? Specifically that protein in the envelope, and then a loss of the actual antigen itself, especially if you're able to kind of initially measure it. So those are kind of the serum checks that we'd like to see happen with treatment for these guys, and then obviously prevent any kind of complications of kind of chronic hepatic damage. Who should specifically receive treatment? So you'll find that a lot of patients, because people can kind of clear this one naturally, you may do kind of a watchful waiting approach to see if they develop any kind of hepatic complications, to see if they can clear it on their own. Obviously, you have to look at the kind of risk for them to have liver-related morbidity, mortality. So, looking at things like what's their kind of follow-up like. Are they likely to be lost to follow-up and you never see this patient again? May guide your hand to whether or not you want to treat. So lots of different factors will come into that decision. Kind of a sample algorithm you can look at. So again, this may not be the end-all therapy, but this is some idea of a way you might treat a patient. You're looking at things like the antigens and the antibodies you're producing, and looking at the actual DNA count for the hepatitis B. And so based on that, you can kind of decide, well, what kind of liver function do they have, right? So if the ALT is, say, less than 2 times the upper limit of normal, just watch them for a while, right? You guys wouldn't know like a normal AST, ALT is? It will kind of depend on the lab you're looking at. Usually like up around 30 is kind of the upper limit. So again, if you're like, already seeing LFTs of like, 200-300, that might be already a sign that you're having significant enough damage that you should start treating, right? So you'll see that term, 2 times upper limit of normal. That's just, basically multiplied by that upper limit of whatever your lab is reporting. So they did have increased LFTs above that two times level. Again, I'm not going to ask you specifically. A patient comes in and their LFTs are 90, and the reference. I'm not going to be that kind of granular about it, but I may ask you which drugs would be most appropriate to treat Hep B, because the therapy is going to change between Hep B and Hep C. Okay, and we'll look at the different drugs we can use here in just a second. So big one, you're going to see interferons pop up pretty frequently. So really MS and Hep B and Hep C are the big places you see the interferons come up. So interferon alpha, one of the varieties you can see, we already saw there's a lot of different varieties, but intron A is one that you can see used for Hep B. This one, they've been around probably the longest out of all the hepatitis treatments, and so they've been used the longest, probably had the best kind of data backing up as far as survival and outcomes as whatnot. Again, we know the interferons work to kind of help prime the host immune system, so hopefully you can kind of mount a better response against the virus and kind of clear it a little bit easier. So you're going to see it have antiviral, anti-proliferative, all these immunomodulatory effects that help kind of suppress this chronic HBV infection. This one, obviously, the interferon being a protein, obviously you cannot take it orally, right, because the stomach acid will kind of deteriorating it. You don't really get good bioavailability. So these do have to be injected. So this one will be given 3 times a week. So it can be pretty inconvenient for a lot of your patients. So this is one of the big things we'll see with Hep C. Now we have oral agents, and so it kind of changes a lot of how we end up treating that. But for the most part, interferon is going to be one of the mainstays of therapy for your hepatitis B. For the most part, you're going to see most patients use a pegylated form, so that peginterferon-alfa is probably going to be the more common one to see being used. And again, you can imagine why, only given once weekly, right? It also has some better efficacy. Yes. Basically, they modify the structure of the molecule to add this like PEG group to it, so like polyethylene glycol, and to make it either last longer. So in this case, you give it once a week versus say 3 times a week. You'll see that done with certain chemo drugs. So there is Erwinia. There's also like pegylated Erwinia. So they do that sometimes with some of these biological products. Yep. So again, we don't know the full kind of optimal duration of treatment. Some people do say sometimes up to 24 months, which can, again, being a protein-based product, can be pretty expensive. So they need to make sure that they can actually have coverage for this and they can actually receive the therapy, right? So it can be problematic. We know that because this is kind of an immunosuppressant in some regards, there is risk for infection, specifically for patients who have already kind of cirrhotic complications, already kind of decompensated. You may see increased risk there. Again, these are going to have a lot of black box warnings associated with them, so especially with neuropsychiatric events, with the autoimmune conditions, ischemic conditions, all kinds of bad things. So if you can avoid using interferons, you're probably going to be better off for the most part, just due to all the black box warnings and all the side effects associated with it, right? And again, because it's kind of kicking up your immune system acutely, you can see those flu-like symptoms, anaphylactic risk, all kinds of other problems with it, okay? It's kind of nasty drugs for the most part. A couple other varieties you can have that might be available for use for hepatitis B. You have lamivudine. You guys remember seeing this one? Right, HIV popped up there. Oh, yeah, you guys remember that one? It's crystal clear. Anyway, so epivir or lamivudine actually has some activity against HBV, although it's not really recommended as first line. Really, the interferons are still kind of recommended first line there. For patients who can't really clear the infection themselves, you can give this one potentially indefinitely, but you do have to worry about relapse and resistance developing in the actual HBV virus. So that's a possibility. And then you also have idefovir, very similar mechanism. Do you guys remember how lamivudine worked? Yeah, you remember what kind of drug it was? Well, specifically, what kind of broader class is it? It's an NRTI, right? So basically preventing the viral DNA from continuing. Yeah, exactly. That elongation process is blocked. So idefovir or Hepcera is going to do kind of the same thing as lamivudine. You can sometimes see this being used if patients have resistance to lamivudine. Sometimes patients will end up switching over to this drug. But you do want to watch the renal function to make sure they don't have any nephrotoxicity that can be seen there. Other drugs you may see being used occasionally, things like entecavir, dalbivudine, or tenofovir. Tenofovir, again, we already saw that back in the HIV section as well. A lot of these are just being used for alternatives if there is resistance already developed, things like that. So just be aware that you may see these drugs being used occasionally for Hep B, right? So just because you see a patient on lamivudine or tenofovir does not necessarily mean they have HIV. Could be other good reasons for them to be on that. Okay. So then Hep C, this is going to be kind of the brunt of the pharmacotherapy that you can get away with Hep C. So before, could a person kind of clear Hep C on their own? Some of them die. Some people could potentially clear it early on, but a lot of patients end up kind of having this chronic Hep C infection, right? And the other problem is that, do we have a vaccine for this? No vaccine for it, right? So once you kind of had it and you did not clear it, then you basically had Hep C for life, right? And so this was a common co-infection, especially with HIV, especially if you were sharing needles, things like that. It was very, very common for patients, especially to have HIV and Hep C together. So it was a big, big problem. As I mentioned, I don't know if I mentioned it to you guys or not, but one of my wife's friends ended up actually contracting it from, he was actually from Asia originally and came over here with his parents and ended up actually contracting it from some of the medical care there. So they may not sterilize their needles appropriately. You know, this was probably 30 some odd years ago. And so, you know, he ended up contracting Hep C that way. So before we used to think, well, you can't cure this. We can only treat it with really kind of nasty drugs, bad side effects, and that was that, right? We're just trying to prolong the inevitable, the cirrhosis and the liver failure that occurs eventually. But nowadays we actually have kind of more revolutionary new treatment. So there'll be some of the new drugs we'll talk about here. And so actually it was kind of a big deal for him because he actually went on treatment with some of these new drugs. And when you end up having kind of a suppressed hepatitis C load, right, and you have all the right kind of seroconversions needed, they actually send you like a cure card basically. It says like, hey, you don't have Hep C anymore. So it's actually kind of a cool little thing, like to get in the card saying like, hey, guess what, you don't have this chronic debilitating disease anymore. So it's really kind of a neat thing we can do nowadays with better living through chemistry, I guess. Yes?
Well, so you're going to go over those right now, right?
Nope, you guys can go look that up and then you would be expected to test them. No, I'm just kidding. Yeah, we'll talk about it. I just want to kind of get that out of the way. But we mentioned that a lot of these acute cases go on to be chronic infections. A lot of people are not able to kind of clear it themselves. Some small subset can, but a lot of patients go on basically due to kind of rapid viral diversification. People can't clear it, so they end up having chronic infections. So our goals here, we would like to have virologic cure, right? So we'd like to get rid of all the virus if possible. And then basically that means you have sustained virologic response, meaning you have non-detectable Hep C RNA, and at least 12 weeks after the end of treatment, you should still have non-detectable levels. Okay, so that's kind of our goal of therapy. And then we can prevent progression to any end-stage liver disease and any other complications of liver failure. That's the thing we're going to be shooting for. Treatment is going to be recommended for all patients. So you need to do the baseline testing, make sure that we'll talk about the baseline testing in just a second, but you need to determine what type of genotype of the virus they have, and that's going to that'll determine what type of drugs you're going to use specifically. Okay. So we mentioned that treatment previously required interferon therapy. We know there's lots of problems with that one. So fortunately, most patients do not need interferon anymore to treat this. There's another drug called ribavirin we'll talk about a little bit later that still gets used occasionally. But before for Hep C, these used to be on ribavirin, interferon. They have very kind of similar toxicities, especially with kind of the neuropsychiatric stuff. So you'd have patients that just be in just the worst mood, all kinds of bad, depression and aggressiveness and all kinds of bad things when they'd be on these drugs together. Fortunately, we don't really have to do that quite as often. So currently, we're going to be treating these patients with an all-oral regimen. So it's going to be all these new drugs we have for 12 to 24 weeks, and that's going to depend on the viral genotype. So we know that they'll be expressed as either GT1 through 6. There's a couple of subsets, so GT1A and 1B end up being the most common ones in the U.S. So those are typically the ones that patients will have most often. Those are the ones that get treated most frequently. Okay, so be aware that not all these drugs are going to have the same activity against all the different genotypes. Okay, so you can't just say, well, every single patient with Hep C should get this drug. There's going to be some variation in why you have to do that testing early. Okay, it's a good point to remember. But anyway, so we'll look at the prices on some of these drugs. So keep in mind they're going to be on this for anywhere between 3 and 6 months. So that will be important when we look at the cost of some of these drugs. Do you think they're cheap? No, they're going to be very expensive. Anyway, the way this cure is going to come about, we have these direct-acting antivirals, these DAA. Do you guys remember the protease inhibitors from the HIV talk? What do they do?
Give you a hump on your head. Is it protease?
Yeah, they inhibit protease.
Which stops it from entering into the host DNA.
No.
It stops and inhibits the cleaving of the proteins.
Perfect. Yeah, it prevents the cleaving of the proteins. You're thinking like integrase inhibitors. The protease inhibitors work to prevent that cleaving of the proteins, basically, right? So the virus will start to produce a big long chain of proteins. Normally protease will come along, cleave it up, and then you have kind of functional HIV virus again, right? With here, the thing that we're going to see is another big long protein chain. And so you have this NS5A inhibitors. Be kind of one of the big groups. So basically, you're going to have these different products either coming along to preventing the actual breakdown of that big long protein chain, right? Or it's going to directly inhibit different components of that. So we'll look at this more in detail. But if by inhibiting any of these components here, whether it be the kind of cleavage of those proteins or preventing the activity of the enzymes themselves, you'll prevent replication of the viral RNA. Okay. We will go into more detail. So the first one we have, and I apologize if I say any of these or have a tough time saying any of these because they are some tough names and they're new drugs to me specifically. So again, these are very, very new drugs in general. So one of the things you'll realize when you're dealing with drugs, especially when they're coming out of clinical trials, and if you think about, there's how many different phases of clinical trials? Multiple. Anyone know how many?
4.
4 phases, right? So what happens in phase 1? Checking for side, yeah. So yeah, essentially you're giving it to healthy people, and you're checking for side effects, right? So you're checking for safety mainly. They do animal testing before that, right? So this will be when you guys come and sit in my pharmacodynamics class, you'll learn all about this. But anyway, yeah. So this is after the animal testing is really figure out, okay, this probably isn't going to make you grow a third arm, right? So they get a new drug approval they get an IND, investigative new drug from the DEA, and so basically they can test it in people that are healthy. Relatively small number of patients, right? Maybe like tens of patients. Stage 2 trials are going to be where they start to test it in sick people who have the actual disease state to look for actual efficacy, look for dosing and things like that. Stage 3, maybe you're dealing with thousands of patients, but they actually have the disease as well. Stage 4, does anyone know what that is? We've always been doing humans, but that's when the drug gets approved and it's out in the market, right? So technically, anytime you take a drug, you're all participants in the phase 4 trials. Okay, that's how things like Vioxx get taken off the market, right? Remember what Vioxx was?
Yeah, it's a COX-2.
It was a COX-2 inhibitor, and we didn't realize when you only test with a drug with thousands of patients, you can't find 1 in a million side effects, right? So this is one of those things where we're treating even a smaller subset, right? Anyone can use an NSAID, but people that have Hep C are a much smaller niche of the population. So there may be side effects that come about. Things that make this come out of the market, who knows? But just be aware that we don't probably know everything with these drugs. They're still pretty new for the most part. So anyway, these are all going to be the Hep C drug. Yeah, these new DAAs, right? So interferon we've known about. We've used that for a long time. Ribavirin we'll talk about later. It's also been around for a long time. These are the new ones that will are very good at treating and curing Hep C. But again, there could be side effects we just don't know about yet. So anyway, so you have Daclatisvir, excuse me, I tried to practice this beforehand, but I get mumble mouth. Daclatisvir or Declenza, oftentimes the brand names are easier to say, right? This one's good against the HCV GT1 and 3, right? So if you had a patient, you tested them, they had GT2, this wouldn't be any good, right? I will not ask on the test, a patient comes in, you diagnose them, they have genotype 2 or 4 or 5 or 6, which drug do you give them? Not going to ask that, but be aware of the fact that you do need to make sure you do that testing beforehand so you don't give them the drug that's going to be ineffective, okay? So anywho, so this one is going to be preventing that RNA replication, and it actually prevents that virion assembly by binding that NS5A protein, right? Basically by binding to it, it helps kind of distort the structure of the protein and impairs the actual function of it. So by not being functional, you can't produce new RNA, can't produce new virion to be released and go and infect another hepatocyte, okay? Other nice things about these drugs is that they're all oral, and that they have no real adjustment for the most part for renal or hepatic insufficiency. You'll see there's 1 or 2 that you have to be careful of if they're already cirrhotic, but for the most part these are pretty well tolerated from that standpoint. Even the side effects aren't really that bad with these drugs. Maybe some headache, nausea, diarrhea, but for the most part really well tolerated. The other thing you have to worry about though is going to be the cost of it, right? So for 1 month, for 28 pills, $20,000, right? And how long are we treating for?
Life.
Not life, right? Because we can cure patients. 3 to 6 months. Okay, so you're talking about a nice Porsche by the end of your treatment. I'd probably rather have no Hep C than a Porsche, but it just depends on your life values, right? But keep in mind, you have to consider things like what's the cost of getting liver transplant? hundreds and hundreds and hundreds of thousands of dollars, right? So this is probably going to be in the insurance company's best interest to cure you of Hep C versus having to worry about things like having cirrhosis. Okay. You have ledipasvir and the sofosbuvir. Harvoni is a good way to say that. This one has pretty broad activity, so it can go against GT1, 4, 5, and 6. So broad activity against several different types. So this will still be good against most of the varieties you'll see here in the U.S. This one will also be inhibiting that NS5A. Okay, the ledipasvir does that. The sofosbuvir is going to be actually a prodrug. This one inhibits a different protein there. So it actually inhibits that NS5B RNA polymerase. So basically it acts as like a chain terminator once it gets incorporated into the viral RNA. Okay, so this one works more similar to what you see with like the NRTIs, right? So it kind of gets incorporated into the DNA or the RNA and then it just stops. Can't produce any longer because it's that chain terminator. Okay, he'll be back though. Anyway, so the drug, the sofosbuvir, is not actually available by itself. So I'm sorry, the sofosbuvir is available by itself sometimes. So you will sometimes, depending on the genotype, see it being added on to other therapies. I'll show you kind of an idea of what those kind of look like. No organ adjustment is needed, so that's beneficial for patients who already have cirrhosis. And again, not a lot of side effects to speak about. But again, this one's also very expensive, $30,000 a month. Okay. You have semapravir or Orlisio. This one is working again on a different protein. Now we're going to be working on this NS3 and 4A protease. This one is specifically used to help cleave that big chain of proteins into the kind of functional subunits. So if you can't cleave that, then you can't. The virus can't actually produce that NS4A, 4B, 5A, 5B. You can't produce any of those proteins because they're still stuck in that big long chain. So this one works more similar to the protease inhibitors than the other ones do. Okay, this one you may see some rash or photosensitivity, but again, pretty well tolerated. But again, kind of warn patients about the kind of dermatologic effects you might see with those. This one you do not want to use by itself. So sometimes you'll see it used in combination with that sofosbuvir, or sometimes it'll be included with, especially patients who have more resistant Hep C. They might use it along with interferon or ribavirin therapy. We'll talk about drug combinations in just a minute. And then you have this ombatasvir. This one is not given by itself, so that's why it doesn't have a brand name listed there. This one is also working to inhibit the NS5A. So you'll either see it being given in combination with this paritabrivir, which is an NS3 or 4A inhibitor. And then you'll also see it used in combination with ritonavir. Right? We already know what ritonavir does. Inhibits 3 or 4, boost up the levels of the paritabrivir. And so that Tecnivi is going to be the brand name for that one. So you'll either see that combination being given with or without this disabuvir. And so you can see a 3-drug combination that's listed there. So again, all of it is dependent on the genotype of the Hep C they have and if they have any resistance to it. Okay. So then the last drug of this group we'll talk about is this ribavirin or Rebitol. This one has been around for quite a while. It's also an injectable medication. We don't know specifically how it works, but we think that it actually works to increase kind of this mutation of the RNA, and by doing that, you eventually cause so many mutations that it can't actually function any longer. So they kind of call this error catastrophe. So imagine you ever work on a computer and get that blue screen of death. Imagine just kind of doing something like that. Also, it's thought to be somewhat immunostimulatory, so it can kind of clear that virus a little bit better as well. Before, it used to be given with interferon, and so we already talked about the psychiatric kind of effects from that. But you can also see increased suicidal ideation, depression, insomnia, all these kind of bad things. So imagine both those drugs together, you're going to have one unhappy patient, right? And then also some risk for hemolytic anemia. Again, this is why we kind of get rid or try to get away from these drugs if possible because of these side effects. And then pregnancy category X, so your patients really need to use 2 forms of birth control, especially for up to 6 months after discontinuation. And so this is one of those ones where even like my wife's friend he was a male, right? And so him and his wife at one point, like she was of childbearing potential, so she had to make sure she was on birth control for that because if he had any contaminated sperm that was transmitted to her, there could still be teratogenesis, right? So one of those things where it could spread from man to woman. So everyone needs to make sure they're using good protection when on this drug. Okay.
If let's say there's a patient that has chronic infection with HIV with Hep C, would there be any synergy with these meds and the cocktails that there are inoculation?
Potentially, like you may be able to get rid of like the ritonavir component of it, you know. So if you're given like a protease inhibitor plus 2 NRTIs, you may be able to use the ritonavir used with HIV regimen to kind of help out with that parotepravir. Hard to say. I don't deal with enough of these patients to know if there's a lot of kind of co-synergy with any of these other medications. Most of them are usually pretty specific for either HIV or specifically for the Hep C. Yeah. So you don't see a lot of combination or cross activity with like you do for the Hep B, right? Because you saw lamivudine and things like that. So that one you can certainly see some synergy there, but you don't really get as much of that with Hep C. Yeah. Okay, so some treatment tips. So ribavirin really only gets continued use in difficult to treat patients. So for instance, if you had previous treatment for Hep C and you failed it due to mutations or due to or if you have a kind of underlying cirrhosis, and again, when you have cirrhosis, kind of what is cirrhosis? Rock hard liver. Never heard it described like that. But it's a very but it's very fibrotic, right? Yeah, so it's a lot of scar tissue basically. So it gets more difficult to treat the Hep C when you have cirrhosis and that really kind of poorly functioning tissue. So sometimes ribavirin gets added on to these regimens in order to help kind of overcome that, right? So resistance, or if they have underlying cirrhosis, sometimes you'll see ribavirin being used. We are getting mostly away from using interferons and peginterferon for the most part, so that's kind of a good thing ever since those direct antiviral agents came out. Again, with cirrhosis, it's very difficult to achieve that kind of sustained virologic response, and so you may need to see some of these drugs being adjusted, their dose adjusted in order to help kind of taking that into account. So for instance, that bemnifosbuvir, parotepravir, and the ritonavir, that one needs to be adjusted. So if they have, or do you guys know how you stage cirrhosis? There's like a child's Pew score that they get. They kind of get graded, you know, A, B, C, and D, essentially. But if they have very severe late-stage cirrhosis, you may need to adjust your dose in order to help make sure you don't have levels kind of jumping too high. So patients that are experienced, that have failed therapy previously, again, you need to consider either doing like resistance testing on them, similar to what you see with like HIV, and then you may need to use that ribavirin. For patients who have kind of an acute exposure to Hep C, so imagine you know, a patient like you know, a nurse who accidentally got stuck with a blood-contaminated needle. About 50% of patients end up clearing that kind of spontaneously within 6 months, and so in some cases, because now we have an absolute cure, we can defer therapy until then. So we mentioned like with HIV, if a nurse kind of stuck her finger with an HIV-infected needle, like do you wait until they have HIV to give them post-exposure prophylaxis? No. This one you can wait a little bit because we do have an absolute cure for it. Okay. Obviously, if they're not going to be compliant, they can lead to further resistance and treatment failures. You have to be careful of that. And then you have to make sure the patient receives their medication every single month, right? So that can be problematic. Finding the right pharmacies that will carry it for you, because again, when pharmacies buy it, again, I was only telling you the pharmacy cost, right? So that was just like if I were to buy this as a pharmacy, $30,000, what gets charged to the patient or what the insurance is covering, it could be well over double, right? So it could be a lot more than that. Yeah, we got to cover our cost, right? So essentially, you know, we need to make sure the patients have a good source to get it, and then a lot of patients, you know, pharmacies may not want to carry it because they're having to hold on to all that stock. So if the patient's not going to come pick it up and they eat that cost, they're not happy about it. So consider all these things. Make sure they have a good avenue to get their meds. They have good coverage for it. That way they can actually get it treated. Okay. So here is an example of how you would kind of decide how to treat your patient. Just memorize this slide and you'll be fine. Okay, not really. But just to give you some examples of kind of how the treatment differs, right? So for instance, if I said, you know, I have a patient who has, you know, HCV genotype 1A, they have cirrhosis, what drug might I need to add on? Yeah, ribavirin, right? So you may need to add that on in order to make sure you get a good full cure. Or just be aware that the treatment is going to change based on what type of genotype you have. Okay, so not every drug is created equal. They will treat different genotypes, and not one treats everything. Okay, so any questions on that section? All right, I will give you a 10-minute break. We'll come back and start hitting up the BDs. Any questions from the hepatitis section? Okay, so we're going to continue on with endocrinology. This is one of my favorite actors ever, Wilford Brimley, the diabetes, mainly for his pronunciation of diabetes. I find that very funny. If I ever hear a health professional say that, I almost cannot keep myself from laughing. It is very tough to go to rounds and like someone say that like non-ironically and not laugh at them. So be very careful when you're on rotations, and it could happen to you. Okay, so we're talking about diabetes. We're going to both talk about type 1 and type 2. Obviously, you guys will need to know how the therapy will differ between both of those because they're treated in some ways very similarly, in some ways very differently. So first off, we'll talk a little bit about glucose homeostasis. We know that all human cells are going to need glucose. They need the sugar in order to work, right? They are useful as kind of precursors for things like lipids, amino acids, all kinds of good stuff. And so the body actually requires around 190 milligrams of glucose per day. That's kind of the minimum you can get. You're probably not going to be feeling too good if you only get that amount, but that's kind of the minimum you need. And again, if you're thinking about the brain, what does the brain only run on? Glucose, right? So you can have the body also, go into what process can it use to make energy? There's glycogenolysis that goes into gluconeogenesis, right? So we have that, but other cells, what can they potentially do to make energy? Yeah, so they can undergo anaerobic metabolism. They can start to metabolize other things in order to make acids, but you can get some short-term amount of energy. But really, the brain has to have glucose, and so this is why insulin is so important. So diabetes, it's going to be this metabolic syndrome. We know, especially in type 2, you can see this elevated glucose that can lead to things like cardiovascular disease. You can see a lot of neuropathic damage that occurs, especially neuropathies, nephropathies, retinopathies, any kind of apathy that can happen to the nerves can probably happen in diabetes. Hyperlipidemia, peripheral vascular disease, lots of other kind of vascular complications that can occur secondary to having high blood glucose for a chronic period of time. So how do we make our diagnosis? Again, most of it's going to be based off symptomatology, and then once you kind of have someone in there into your clinic to kind of they're complaining of things like eating all the time or drinking all the time or peeing all the time, that's when you're going to start doing your testing, right? And so you can look for things like random plasma glucoses greater than 200. That's usually a pretty good sign of diabetes. Their fasting is going to be elevated sometimes. And do you guys know who probably most often gets glucose tolerance tests? Pregnant women, yeah. So a lot of pregnant women get oral glucose challenges in order to make sure that they do not have gestational diabetes. That's one of those things where you take a big load of glucose and they would check your blood sugar usually 2 hours after. There's a couple different methods for doing it, but essentially they can check that. And if you have kind of impaired glucose tolerance, which means essentially the glucose is staying in the bloodstream and not making it to the cells, that's a sign of diabetes, right? And so also looking at your A1C, what is A1C? It's your glycosylated hemoglobin. What does that mean, though?
Sugar sticks to it after 3 months.
3 months.
How much sugar is binding to the red blood cell?
Yeah, so basically it kind of gives you, so why 3 months? Why did you mention that one?
Because it's just accumulating with
Lifetime of the red blood cell, right? Red blood cells stick around for about 3 months, so it kind of gives you an idea what the average glucose level is for the body over the past 3 months, okay? So this is another good way to tell us if you have really kind of on average elevated glucose levels, your A1C is going to be elevated. So usually anything above 6.5 would be considered abnormal. 1 point increase in A1C, do you guys know what that correlates to in average glucose?
26.7.
I always heard 35. Did you guys hear something different?
We heard 26.7.
I learned 35, so somewhere around some of the 30ish range. I won't ask you that on a test, but that was a general rule of thumb I always used, at least in rotations and whatnot. That every point above that is roughly around 35. But if you heard something a little lower, then that's fine as well. But yeah, so it kind of gives you an idea what their average glucose level is at any given time. So type 1 diabetes, this is around 10% of the patients you run into with diabetes. They're going to require exogenous insulin for survival. Kind of what's their pathophysiology? Autoimmune. What happens? Beta cells are destroyed, and those are responsible for making insulin. So no beta cells, no insulin, hyperglycemia. Yep, you don't want to do that. So what happens if they get too high glucose for too long? Yeah, diabetic ketoacidosis. DK is the main thing. If you're going to die from type 1 diabetes, it's either hypoglycemia or it's going to be from DK. And I've seen some really, really bad DKs where if they don't come in for several days, I've seen cerebral edema associated with that. I've seen really, really bad cases. I mean, some kids gone brain dead after really bad DK. So we really want to keep these patients out of this. There's type 2, which is going to be what's kind of the pathophysiology for type 2. Overweight, insulin resistance, right? So what does insulin resistance mean?
The insulin doesn't really unlock the cell.
Yeah, I like that idea. So usually insulin's a kind of a key for the cells, right? It kind of opens it up for things like amino acids and fats and carbohydrates. But if that key's not really fitting the lock anymore, because the lock has gotten like down-regulated because you just are, your body's just constantly spitting out insulin because you, have a poor diet or you're overweight or things like that. All that can lead to insulin resistance. There's certainly some genetic components as well, but a lot of it's related back to lifestyle. Okay, so if you're just constantly hammering those beta cells to release more insulin, you can wear out your beta cells as well, which can be another kind of component to that. So we'll talk more about that in detail. There's kind of a type 1.5, which is considered to be kind of a latent autoimmune diabetes, which would end up being treated kind of similarly to type 1 if they have extensive enough destruction of the beta cells. I mentioned gestational diabetes, which is just associated with pregnancy, and then you can also have kind of a pre-diabetes type stage. Impaired fasting glucose is really that level where you're kind of just not quite high enough for the fasting glucose to be considered diabetic, but definitely should be a warning sign. Hopefully get people to get their diet in check. So most often with the morbidity and mortality with type 1, like renal failure can be a really bad thing. So you can see a kind of constant shredding of the glucose through the glomerulus is problematic. And then for usually type 2, macrovascular disease is the bigger issue, right? Because they usually already have some kind of predisposed cardiovascular risk anyway. Increased atherosclerosis, the glucose just doesn't help that. So and then looking at things like, for type 1, obviously certain viruses may be involved, family history, there's a lot of genetics involved here. But with type 2, certainly there's some family history, but ethnicity, obesity, lifestyle can all affect that as well. So getting down to the actual pathophysiology of this, so looking in the pancreas, we like our pancreas, it's a very useful organ. The beta cells is the main thing we're going to be looking at as far as releasing insulin, right? We'll talk about kind of how insulin gets released in that process there, because that will be really important for where our drug targets are working at, right? But there's some other components here really important too, so things like glucagon. What does glucagon do? So it increases blood glucose. How does it do that?
By inhibiting insulin production.
Doesn't really inhibit insulin production necessarily. Yeah, so it stimulates the liver too. Okay, how does it do that? What's that process called? Gluconeogenesis. And where does it get turned? Where does the glucose come from?
Glucose comes from
Glycogen, right? So you have glycogenolysis, and then you get gluconeogenesis, and then boom, you got blood sugar, right? That'll be important when you're talking about things like treating hypoglycemia, because if you have a patient who has no glycogen stores, so they have kind of like a long-standing hypoglycemia, they've been like that for several hours or a day, and they're really kind of stressed out, they might not have a lot of glycogen stores. So I can give them as much glucagon as you want. It doesn't actually make their glucose go up, right? They need just straight sugar to increase that. So we'll talk about that, but keep those kind of things in mind. Other things that are important include things like somatostatin. That can be really important when you're looking at things like post food satiety, like when do people actually stop being hungry and they stop eating. This can be problematic for patients with kind of long-standing poor lifestyle choices. We'll talk about some drugs that kind of affect that pathway as well. So I mentioned glucagon affecting the GI tract, right? What does it do?
Paralyzes, like non-motility.
Yeah, so it kind of stops motility, but the big thing I see used also being used for is it actually will help to release kind of the lower esophageal sphincter tone. So sometimes if I have patients with a foreign body that's stuck in the esophagus, so kids like to put things in their mouth, they like to get things, swallow things, they will actually get it lodged in the esophagus, and then sometimes they'll use glucagon to try to loosen that up to have it pass. Yeah, so it doesn't ever work really, but usually kind of the GI docs are always, because it's usually like 9 o'clock on a Saturday night or something like that. And the GI docs like, just give them glucagon, see if that works first, and then of course they do the X-ray, still there, and so they'll say, okay, well I guess I'll come in and do the scope.
I had it work on this.
Yeah. Okay. So yeah, occasionally it will work, but for the most part I don't see it really being super useful. I actually had a good foreign body ingestion case the other day at the hospital. So are swallowing magnets a problem?
Yes.
Why is that a problem?
If you swallow two of them,
Why is it 2 of them?
because they'll link up.
Right, so if I swallow 2 of them and they were stuck together, it's not really a big problem. But yeah, so if they're separate and then they come together, it's at different parts of the bowel, they can clink together, and then that can cause what? Adhesions, perforations, septicemia. Yeah, so that pressure leads that tissue necrosis and get a perforation to occur. So we actually had a kid who was 6, I believe. He probably should have known better. He's old enough to know better. But you guys know those little buckyballs little kind of rare earth magnets. It's like a little toy, like a desk toy. I actually have a bunch at my house, and I probably need to get rid of because of my baby. Yeah. Anyway, so they're very strong little rare earth magnets, and they're little ball shaped. So of course, kids want to eat that. So the kid actually swallowed it on Tuesday. Didn't tell anyone about it until Friday. They did the X-ray at KUB, and of course, they saw a big lump of magnets in the kid's bowel, and so they ended up transferring the kid over to Nemours to get further care. GI doc went in. Did an endoscopy to try to see if they could remove it. Couldn't remove it. Had to call surgery in to open the kid up, and sure enough, there had been 2 different points that had connected together between the small and the large intestine. Yeah, kid did fine, as far as I know, but had he waited longer, yeah, it could have been really, really bad, right? Yeah, no significant damage done. So they caught it early enough, hadn't really been sitting there. But of course, 6-year-old, it's funny, one of the med students went to go see the kid and interview him, and he's like, yeah, the kid's really, really quiet. I don't know why. And they're like, because he's in trouble. His mom's going to kill him probably after this. So anywho, so just interesting things you can see with foreign body ingestions. Anywho, so after that, a little side note there. So again, looking at your alpha cells and your beta cells in the pancreas. Obviously, beta cells are super important for releasing insulin from us, and you end up seeing, especially with type 2 diabetics, with type 1 diabetics, they basically have this autoimmune condition that just wipes out their beta cells, so they don't really have any insulin to produce. Do they have any insulin resistance? Yeah, so it's not super common, but especially early on in treatment, they may not, right? So they're not really releasing any insulin to get resistant to, but you will see some cases where they're really poorly controlled and things like that can definitely develop. Type 2 diabetics, so this is like, I've been eating Twinkies all my life and constantly kind of hammering my beta cells to release a lot of insulin. My cells, are just not really responding to it as well, and the beta cells are going to take a hit as well. So eventually they can get to a point where they're not really releasing a ton of insulin, and that's where you see a lot of those patients have to transition over, okay? So you can see beta cell function kind of go down, and usually your pancreas has a decent amount of reserve. So by the time they actually get diagnosed, they've already got to have a significant destruction of those beta cells, right? So you're kind of fighting a losing battle at that point. You're just really trying to help salvage and try to, you want to sensitize the body as much as you can to insulin, and give drugs that maybe can increase levels of insulin naturally. So we'll look at some drugs to do that a little bit later. So, mentioned the autoimmune disease. That's usually the most common reason for type 1 diabetes to develop there. There could be some non-immune or idiopathic, but it's usually kind of the more rare type. But you can actually measure the antibodies against the beta cells there. So insulin, when it gets released, is it actually the active form of insulin? Comes as proinsulin, right? So it's actually a prodrug that gets released from your body. So insulin gets connected to what? Or what's it normally connected to when it gets released? On the slide? C-peptide, yeah. So it actually comes apart with the C-peptide, and that ends up getting cleaved. And then C-peptide is actually kind of interesting because if you had someone who died of an apparent insulin overdose, how would you actually diagnose that? Measure C-peptide. So someone who had, say, I took a bunch of Lantus and injected it into myself, how could you tell if that was my own body's insulin or not my insulin? You look at the C-peptide. If the C-peptide is low, then you would know that it was exogenous insulin, versus if I had like an insulinoma or some other reason, then you would actually see high C-peptide levels. So sometimes you can use that for investigations to see if someone's wife got really tired of him making bad jokes all the time and then decided to murder him. That's the problem being married to a pharmacist. Just be aware of that. Anywho, so again, you're going to have that cleavage that occurs. You're going to see C-peptide fall away, and the insulin can have its actual activity there. Typically, the liver clears most of the insulin, but a decent amount does go through the kidney. So if you have patients who have poor kidney function, as type 2 diabetics can develop, or type 1 diabetics as well, they can actually end up seeing longer half-lives for insulin. So if you see kind of unexpected hypoglycemia, that could be a reason for it. Okay, because insulin will stick around for a little bit longer. Has a relatively short half-life, so this is why you're going to see that the dosage form of insulin that we give is super important, because you're going to have some that are very rapid-acting, that don't stick around for very long, and some that are very long-acting. And a lot of it is related back to the dosage forms and how they actually have their release characteristics. So, normally the mechanism that we have here, so how does insulin get released from the beta cell? So basically the pancreas gets exposed to glucose. The glucose levels go up, and it's going to bind this GLUT2 transporter on the beta cells, right? So it's going to do, and you guys have covered this before, right? I see one nod and a bunch of blank stares. I'm going to assume you might have heard it before, but some repetition won't hurt, right? So anyway, the GLUT2 transporters get exposed to glucose. That gets internalized into the beta cell, and then basically you're going to start to stimulate that TCA cycle. That's the citric acid cycle. Get ATP starting to form there. ATP levels will go up, right? ATP being what? It's energy. Anyone know the name? Adenosine triphosphate. All right, so that's high energy phosphate bonds. Basically, what that does then is close these potassium channels. Okay. Once you have the potassium channels closed, you're going to cause the cell to depolarize, and it's going to open up calcium channels. Calcium opens up, calcium flows into the cell, and that's going to end up releasing these vesicles of insulin out into the bloodstream. Okay. The only reason why I go into this much detail here is because this is where your sulfonylureas work. Okay, so this is a very common group of drugs for type 2 diabetics to be on. So it's important to know how these drugs are working specifically. Here's a picture of what happens here. So if I were to get laser pointer, so here's your GLUT2 transporter where glucose comes in, gets metabolized into ATP, and then that closes these potassium channels. Normally potassium would leave the cell to leave it hyperpolarized, but once you close them, then that's going to cause an action potential to come along here and open up these calcium channels. Calcium comes in, and it's going to cause release of the insulin vesicles. Okay, insulin goes in the bloodstream and kind of does this thing. So this will come back up when we talk about sulfonylureas. Once insulin is out into the bloodstream, it's going to stimulate glucose uptake into the target tissues. This is primarily through the GLUT4 transporters. There's lots of other GLUT transporters as well, but GLUT4 is usually used in a lot of the peripheral tissues. It's going to cause this kind of phosphorylation cascade within the cells that's going to lead glucose to be transported into the cell. And then you're also going to see other things right into the cell as well. So you see things like amino acids, you're going to see lipids, and all kinds of other things getting introduced into the cell once you have insulin bind it, right, and start to kind of stimulate that activity. And then glucose can either be used for direct energy, or it can end up being stored up for energy later. What does it get stored as? Glycogen, right? So glycogen storage are really going to be important for kind of stimulating blood glucose once you get hypoglycemic. Anyway, this is a little bit more complicated than what we need to get into, but just realize that you have these kind of tyrosine phosphate proteins that are getting phosphorylated here once insulin binds, and that causes these GLUT4 transporters actually getting put out onto that cell surface, right? So by stimulating that, you have more receptors getting put out on the cell surface, more glucose can get in. Okay. This is really important for our type 2 diabetics, especially because as they get more insulin resistant, you can see less of this occurring, right? Less glucose gets, or transporters get put on that cell surface, so we need drugs that can help to resensitize the body to insulin. So insulin sensitizers are going to be super important cornerstones of therapy, especially for type 2 diabetics. So again, just some examples of different GLUT transporters you might find out there. Again, things that are working on, especially in the muscle and the adipose tissue, like the GLUT4, are probably going to be your primary ones that you end up seeing getting kind of resistant over time. GLUT2 being more important in the beta cells. I'm not going to get super granular on glucose transporters on the test, so just this is more for illustrative purposes. So. So looking at different things that it will actually help to stimulate. So if you're looking at the liver is really important for glucose homeostasis. When insulin stimulates the liver, you're going to have storage of glucose and glycogen. You can also see conversion of things like fatty acids, VLDL, and then eventually gets converted into adipose tissue, right? So this is why, learning about, diets and things like that growing up, I came from a very large family. Very wide, large family. And so we also always used to get low-fat foods, right? Because fat made you fat. Not really the case. Carbohydrates make you fat because all of that extra excess glucose gets turned into glycogen, which gets turned into adipose tissue eventually, right? So this is what's being stimulated by insulin on the liver itself. When you have insulin being released in excess, you're also going to end up having decreased activity of glycogenolysis and gluconeogenesis because the liver thinks, hey, I must have enough glucose around. I don't really need to stimulate these processes because insulin's here. Okay. Skeletal muscle tissue, again, you're going to have increased uptake of glycogen or increased storage of carbohydrates as glycogen. Also is where you get amino acids and things like that being stored. This is why insulin is a anabolic steroid. When you get down to it, right? So sometimes you'll see bodybuilders will use insulin, especially like post-workouts, and they will consume it with a lot of protein, a lot of sugar, in order to help kind of fill up the skeletal muscle and kind of help stimulate growth there. Okay, so sometimes you will see that if you ever have like really like big buff dude who is super hypoglycemic and had some needles next to him, you might have an idea of what he was injecting, right? So, and then in the adipose tissue, again, you're going to be storing things as fatty acids and triglycerides, and it'll also inhibit that conversion when it's around. So looking at insulin release, it's really important to realize that this is not just kind of a basal level of insulin you're releasing all the time. Like insulin gets stimulated in the presence of glucose. So when do you most often have increases in glucose? What time frame?
After eating.
after eating, right? When you have mealtime, when you absorb food and carbohydrates and stuff, that's when insulin gets released most often. So if you were to look at these levels here, so again, this part of the chart here, looking at insulin, you can see here that you may have some kind of basal amount of insulin being released, right? Basal just being a constant amount being released throughout the day, and then you're going to have spikes of it occur around mealtime, right? And it's kind of this biphasic kind of spiking that occurs. But this is when insulin levels are going to increase. Is usually after food. Usually, when you have a spike up in your glucose, your body responds by spiking up insulin release. Okay. When we are dosing patients on insulin for diabetes, we're trying to mimic this process. Okay. Ideally, if we could, we'd have some machine that could just act as an artificial pancreas and monitor blood glucose all the time and release insulin in response to that, but we are not perfectly there yet. We're starting to get there, but not perfect yet. We will end up seeing that we're trying to mimic this process as much as possible. So we're going to have a mixture of insulins being used for most patients who are dependent on it, usually long-acting forms, along with short-acting forms as well. Right? So long-acting is kind of mimicking this basal form of insulin that your pancreas is normally releasing, and then you have mealtime insulin as well in response to the big spikes in glucose. Okay. So there are lots of different insulin formulations that are out there, around 17 or so now. We actually have a couple of different dosage forms you might actually find being used now. We actually have inhaled insulin. There actually used to be an older inhaled insulin preparation when I was in school many moons ago, but that actually got taken off the market because no one bought it. Now there's another new one. I don't know if anyone's going to buy that or not, but we'll see. Anyway, big differences in insulins are going to be their onset of activity, their duration of action, and then also some of the solubility characteristics. Some of these actually, when they get put into the muscle, aren't very soluble, and it takes time for them to kind of break down, and that's how you end up having kind of long-acting formulations. I won't get super in-depth on that part of it, but just realize that the pharmacokinetics differ very greatly depending on the type of insulin you're dealing with. You can find that the pharmacokinetics can be altered by adding zinc to it, right? So you can have lente formulations that act longer. Adding protamine. You guys remember where protamine comes from? The same exact thing, yeah. So the drug we use for heparin reversal can be added to insulin. That's where you get your MPH forms, right? So those are going to be longer acting forms of insulin. Does anyone know where the protamine comes from? It's a salmon sperm, right? Yeah, so you get protamine from, I know it's weird. I don't know what the scientists who discovered that was thinking, but that's what he figured out. But anyway, and then you can also have other analogs. So, normally, insulin's a protein, right? Which is why we have to give insulin most often by what route? Not IM, usually sub-Q, right? So because it's a protein, you can't give it orally, right? The stomach acid will just destroy it. So it's a string of proteins. If you can change some of those amino acids, you can get also differences in the release characteristics of it, or the activity of it. So you'll see some that are changing the amino acid sequence to get different actions. So for instance, you can look here at what the insulin normally looks like. This is the proinsulin. You can tell because it has a C peptide still attached to it, so normally it would cleave these sulfide bonds here, and then you end up getting the insulin itself being released. Okay, so by changing some of these different amino acids, by doing things like changing out a proline for a lysine, and this lysine for a proline, you get lispro. That's where the name actually comes from, right? Or if you were to put an aspartate instead. So changing out those amino acids can change the formulation. I'm not going to make you draw out the amino acid sequence of insulin or anything like that, but just realize this is one method to change the activity. So where do we get our insulin from? We used to get it from animals, right? Because it's good enough for other mammals, it should be good enough for us, right? So we used to get it from pigs or beef. We don't really use the beef too much because anytime you're injecting foreign animal proteins in the body, yeah, you can have a reaction, right? So the same reason why you have problems with like coral snake antivenom, it's made out of full horse antibodies. People have anaphylaxis to it like crazy, right? So foreign protein is never a good thing. We typically don't use the pork formulation either. That is actually available by special order if you had some patient who had really lots of contraindications to every other form. Nowadays, we'll either use human insulin. We have recombinant forms that we can make in either an E. coli or yeast. So basically, we kind of inject these plasmids into these either E. coli or yeast, and it actually produces human insulin themselves. Okay. Basically, just the different companies use different methods. So like Lilly products end up getting like the Humulin products, and that's where they use E. coli, versus like Novolin comes from Novo Nordisk. You'll realize like if you go to like work in a hospital or something like that, they'll have like one type of insulin that's on the formulary, and that's just what you use, right? Or patients, so we sometimes we'll have issues where we have a lot of diabetic, type 1 diabetic patients coming into Nemours, especially if they have like DKA or something like that. They may be on Humulin, we have to switch them over to Novolin, and vice versa, depending on what they're on previously. But in terms of activity, not a big difference between these two. So the different forms you may have, so there's ultra short acting. So you have things like Lispro, Aspart, and Glulisine. We'll mention that the brand names are in just a little bit of a table for that. But anyway, and then you have short acting regular insulin. Okay, when do you think these would be most often used? Yep. Should you take the insulin after you eat? Yeah, usually take it before. Well, it depends. So there's one form that you can take with food, but typically you would do it kind of beforehand, right? So again, this is one of those things where you have to kind of anticipate what are you actually going to eat, right? So yes, we'll talk about different kind of methods for doing that. But the idea is to prevent that big spike in blood glucose. You like to kind of keep things kind of at a steady level. The longer acting forms, like intermediate acting, like the NPH, that one is the one that has a protamine in it. You have long acting forms. I don't really see ultra lente being used very frequently, but I do see a lot of the ultra long acting drugs being used, like Glargine and Detamir, and this Degludec is probably the newest one that I've seen at least. And then you have the inhaled version, Afrezza. This is actually going to be used for more kind of short acting mealtime type insulin. So how did the different activity profiles kind of look between these two? So if you can imagine the short-acting formulations, these are going to be better for big spikes in glucose, right? So like after you eat or something like that, this is going to be the best way to treat kind of acute hyperglycemia as well. So you guys have heard of sliding scale insulin regimens? What does sliding scale mean? Yeah, so I'll talk about like carb counting versus sliding scales a little bit differently, just for differentiation purposes. But like most often, like in the hospital setting, we do sliding scales based on what their blood glucose is right at that moment, right? So it's really kind of a reactionary kind of measure where you check their blood glucose and it's 200, you give this many units, or if it's 250, you give this many, whatever happens to be. But using short-acting or regular insulin is really good for treating either acute hyperglycemia or for dealing with like mealtime boluses of glucose. Okay. Then when you get into longer-acting forms, this is better for providing kind of that basal coverage. So they don't really have as big of a peak effect, and you get much longer duration of activity. So things like Detamir and Glargine, these are really good for kind of 24-hour coverage, right? So you might see someone who, say, is on insulin Detamir one time in the morning, and then they'll be on, say, regular insulin, or they'll be on like on a short-acting insulin at meals, right? And then maybe once at bedtime based on their blood glucose. So lots of different insulin regimens you may see people being put on. But that's generally what you're going to see, right? So if you see someone who, if you imagine, patients, especially if they have cognitive issues or if they have, sight issues or things like that, and they end up mixing up their insulins, that can really kind of throw them for a loop, right? Because someone gets too much of their long-acting form that lasts for 24 hours, right? I don't really have a good way to counteract that besides just giving them more glucose. Okay, so insulin errors, I will mention, is going to be a huge issue. You do not want to screw up with insulin. You can kill someone real easy. Okay, is the patient just asleep, or are they having a hypoglycemic coma? Well, they're seizing now, probably hypoglycemic coma, right? These are the things you have to be considerate of. We have errors where, usually, how do you dose insulin normally? Is it milligrams or micrograms?
No, units.
Units. Yeah, it's in always in units, right? There's different concentrations. So you can have U100, there's U500, which is for like really severe diabetics who need like a lot of insulin. If you mix those up and you give someone a 5-time overdose, that's bad news, right? You can reverse it by giving them more dextrose, but just be aware that insulin errors are very problematic. It's a huge med safety thing to keep in mind when you're out there practicing, okay? Don't screw up with insulin. Okay, how do we get insulin into our patients? This is actually kind of a cool picture in the middle here. This is the first artificial or continuous subcutaneous insulin delivery device looked like. So you can imagine wearing that backpack around and having had that pump on you. Like, yeah. Fortunately, we don't have to deal with that anymore. Usually, the most conventional way to get insulin into the body is going to be by injection, usually by subcutaneous route. Okay. Very rarely do we give IV insulin. Sometimes you might do that for say, DKA or things like that. So we usually only do short-acting or regular type insulin. Okay, regular or shorter-acting insulin is okay to give IV. You never want to give long-acting forms IV. Okay, that's a general rule of thumb. But anyway, so you can give it via subcutaneous injection, which is usually the most common. They have portable pen injectors that have kind of cartridges full of insulin that can be useful. Usually those have like little dials so you can kind of dial in what your dose is going to be and just inject that, which is pretty convenient. And then you even have the inhaled form. So you can see here how you can kind of have a cartridge of insulin. that basically you can kind of put into the thing here. It kind of closes up, and then you have the inhalation of the insulin. Again, because the lungs are very vascular, you can absorb lots of things through there, so you can actually have some activity with that. And then the thing that I see a lot more, in especially like type 1 diabetics, especially in children, are using continuous subcutaneous insulin pumps, right? So this is really good for patients who are kind of well maintained on subcutaneous insulin, like they are really good about watching their sugars and carb counting, all this kinds of good stuff. You can switch them over to a pump, and they can maintain that pretty well. So I'll have 8-year-old patients even who are way better at managing diabetes than I'll ever be, just because they do it every single day, right? They're checking their blood glucose, and we'd have to check them out when they come in on the inpatient side to make sure they know how to work their pump and everything's working okay. Because pumps they can't have errors, right? So they can't have pump malfunctions where they get too much insulin and come in and have issues, or they get really hyperglycemic. But they can go through and basically program in what their boluses are, what their basal insulin rate, because normally the thing will be providing a basal insulin rate throughout the day, and then they can program in boluses based on either their carb counting or sliding scale and things like that. So it's a very, very convenient way for all these patients to manage themselves without having to do kind of constant injections throughout the day. So pretty cool technology you have there.
Would you recommend a pump for a baby, like an old and younger kid?
No, so the thing with pumps is you really need to make sure the patient is able to manage it themselves for the most part, right? So you may see some patients that get some help from parents and whatnot, but you'll find these kids will, kids are like they're sponges anyway, so they'll get really good at adapting to this. But say, for instance, you have a kid who is not well controlled. They're always, their diet is crap. They are constantly coming in for hyperglycemic crises and things like that. They're not a good candidate for this, right? But if you have someone who is like really good about counting their carbs, they're always, their blood sugar, usually they keep journals and things like that to watch their readings, like they keep everything in line. They're better candidates for that sort of thing, right? The cognitive issues or things like that, they may not be the right person, right? So, but yeah, you can talk to these kids, and they are experts at managing their own diabetes. It's actually kind of awesome to see that. But keep in mind that they're coming in like, a lot of it may not be pump issues. It could be they get a virus or something like that can throw their blood sugars out of whack. So they can come in for lots of different reasons, not necessarily related to the insulin itself.
With the inhaled version, how do you accurately monitor how much insulin you're receiving?
So there's a certain number of units that are in the cartridge. I think it's like between 4 and 8, I think. I don't remember off the top of my head. But basically, a certain number of units they're getting. And of course, the thing with inhaled drugs is it's all about technique, right? So if they have poor technique and they inhale incorrectly, or they may get all the drug in the back of the throat, and then they swallow it all, which is not going to be very effective. Or if they do something goofy like breathe into it, and I don't know if that's a really big issue or not with that one. But yeah, so really you can only tell if their technique is good by watching their blood sugar, right? Yeah, so that's kind of the issue. So again, it's good for patients who don't want to inject themselves, but again, I don't know what the kind of long-term efficacy is. Looking at it's all patient education, make sure they're using it right. Okay. What type of insulin do you think we use in the pumps? Yep, you only can use fast-acting insulins, right? So you normally see like Novolin or Humulin pumps. You don't see like Levemir or Dedamir or Glargine pumps, because that's long-acting insulin, right? You can't titrate that at all. Like once you give it, like it's kind of there for 24 hours. The short-acting forms you can titrate, and so you can use, say I'm going to give so many units per hour throughout the day, and then I'm going to eat this many carbs. I'm going to give myself this many unit bolus, right? So they're programming all that stuff in. They're programming in all their blood sugar readings and stuff like that. Some of them even have like connectivity to smartphones and things like that, so you can get all your readings right up on your phone. Like it's pretty, yeah, Apple Watch and things like that. Like it's pretty neat how far the technology's come for these patients. So here is the list of the different insulins. Should be familiar with which category they fall into. So if I mention Insulin List Pro, you should know it's a rapid-acting insulin, right? So you have 3 rapid-acting ones. You have the Humalog and Novolog, so List Pro and Aspart. These work interchangeably. And then you have the Apidra or insulin glulisine. This is like really, really super fast-acting insulin. This is the one that when it got marketed, it said that you can actually take it with meals instead of maybe taking it a little bit beforehand. Regular acting insulin, again, you have Humulin R, Novolin R. These act identically to one another. It's just the way they actually got the insulin produced in the first place. These are not going to have as good a titratability as you would see with the rapid acting ones, but are still short acting in nature. And then you have your MPHs, which are normally denoted by Humulin N Novolin N, like those are how you will know that's an NPH formulation. And then you have your long-acting one. So you have like Lantus, Levemir, and then this new one, Tresiba, or insulin degludec. So those are going to be your long-acting once daily usually. Sometimes you'll see really severe diabetics being on some of these like twice daily if they have kind of poor control or they need really big doses. I'm going to break that up into twice daily. But usually it's just once. It's important to know the NPHs, because they're more intermediate acting, those ones you do typically see given twice a day, right? So they may do it in the morning and at night to make sure they get a good 24-hour coverage. Okay. There's lots of different like kind of premixed formulations. So sometimes you'll see long-acting and short-acting actually being put together. So if you ever see like a Humalog mix, 75-25 is just kind of telling you what the composition of that insulin product is. So it'll have like so much protamine plus Lispro. So you'll see some varieties like that. You will see these concentrated insulins. You should be very, very scared anytime you're using U500, right? You do not want to screw this up and give someone way too much insulin. Lots of dosing errors that can occur because of this, because someone may think you mean this type of insulin, someone grabs the wrong one, and you have problems with that. Then obviously the Afrezza. I only mention this here because I think it's got the coolest insulin name, the Technosphere. I just wish more drugs were named as cool as that. I think on Dancitron is one of the other cool one. Sounds like a funky robot. Anywho, I'm not going to make you memorize this slide here, but you will have some idea again when you kind of compartmentalize these different insulins into different different pharmacokinetic profiles, right? So the rapid acting ones, you can see their onset here is very quick, right? So between 15 and 30 minutes or so. Okay, the peak effect. We saw the short-acting ones, you have much higher peaks, but they peak pretty early, right? So 1 to 2 hours or so, and then they have a relatively short duration, okay? Whereas with something like a long-acting forms, their onset's going to take a little bit longer, right? So these are not good for treating acute hyperglycemia, and they have a lot longer duration of action, okay? So they're going to be lasting throughout the day. So it's not uncommon you have patients taking, say, intermediate or long-acting at the same time as they are the rapid-acting, say, right in the morning, and then, they may not take the, long-acting form until the next day. Whereas they'll still get, the rapid-acting insulin, at mealtime and stuff. Okay. I won't really get into this too much, but there's you'll note that some of these insulins are clear, some of them are cloudy. Usually the NPH forms are cloudy. That's only important for patients who are mixing insulins, right? So in order to decrease the number of injections that patients have to give themselves, sometimes you can mix the long-acting NPH forms along with the short-acting insulins. You never want to mix these, I guess intermediate, I should say, intermediate acting NPH. You never want to mix your long acting forms with the rapid acting. Okay, those two never go together. But sometimes you'll see patients who will mix their clear and cloudy insulin together and give one shot instead of two. Okay, so we mentioned complications of insulin, so hypoglycemia obviously being the biggest one, so you can overdo it. Some patients can have kind of differences in their insulin tolerance over time, or sometimes if they get sick, they can really throw their blood sugar kind of all over the place. So just be aware of that. For patients who especially have very high insulin requirements, this is where you use the kind of the more concentrated forms. Obviously, you're going to be more at risk for hypoglycemia if you goof up those doses, right? Other things you can see, you can have immunopathology that can occur, so you can actually have an insulin allergy. So very rarely do people actually have allergies to insulin, because nowadays we inject human insulin, right? It's just made in E. coli or yeast or something like that. So very, very rarely does that occur. But you may end up having actual immune insulin resistance. And so this can actually be a case where you start producing IgG antibodies against the insulin. Again, I don't know what the actual occurrence of that is, but it could, if a patient's blood glucose starts to creep up, it could be, they're taking their insulin like they're supposed to and whatnot, but it's not working as well. That could be a reason for that. Okay, and you can see some injection. Oh yes.
How does that immune insulin resistance? How does it show up? Why is the patient
I think it would be basically that you would see the antibodies are basically just neutralizing the insulin. You don't see like an actual anaphylactic reaction like you would with like the bovine products or something. It would just be where the insulin's not as effective. And so you see their blood glucose kind of just creeping up, and the insulin would be less effective given the same doses.
would it be like a skin reaction or anything?
Not that I'm aware of. No, because this all happened in the bloodstream. Yeah, essentially. Yeah.
Because if you see those patients' sugars keep going up even though they're on the insulin, wouldn't you just be like, oh, maybe I just need to bump up the dose?
Yeah, that's your initial reaction, right? So they're not being compliant with therapy, or they're more insulin resistant. I need to give them more, whatever happens to be.
So how would you distinguish it from that?
That's why it's hard to tell, right? So you may treat a patient for years and never really know they had this issue pop up. They're usually like, man, this person's really hard to control, and they say they're claiming to be, so it could be related to that. There's not really a good way to overcome it besides just give more insulin anyway, right? So there's not a whole lot you can do about it. But that could be a reason for poor glucose control, even though you have a really compliant patient. So again, I don't know how often that actually pops up, so I don't know what the clinical implications are. And then also you want to make sure, because how do we store insulin? You should do it in the fridge. Because they're proteins, you leave them out in the heat. And again, being in Florida, one of the biggest things you have to ask your patients if their blood glucose is not being well controlled is like, well, where'd you leave it at? Most patients are probably pretty good at leaving it in the fridge, but if you leave it on the dash and it's the middle of the summer, guess what? All those proteins are going to denature. It's no good. But you can have some injection reactions, so you might want to make sure you kind of roll it up in your hands and kind of warm it up a bit to make sure you don't get a lot of this kind of that little injection reaction there. Okay. You want to make sure patients are kind of rotating sites as far as injecting, because you can see some lipodystrophy if you did the same injection every single time. So be aware of that. And then obviously, because I mentioned insulin is a anabolic steroid, weight gain is going to be a concern here, right? We're going to look at different therapies for diabetes, both type 1 and type 2, and we're going to see the risk for weight gain. Anything increasing insulin, including insulin, can cause weight gain. We'll see some drugs are actually good about actually dropping weight. I know my uncle, who is a big redneck, big hunter, loves to eat bacon, loves to eat brisket, and big dude, right? He, of course, has diabetes. He looks a lot like Wilford Brimley now that I mention it. He doesn't say diabetes, though, which is unfortunate. But anywho, definitely had diabetes, and he actually got put on one of these newer drugs, one we'll talk about later, called duraglutide, and he ended up dropping weight like crazy, right? So he looks like almost like a skeleton wearing his old clothes and whatnot. So some of these are going to have positive effects on weight, some are going to have negative effects. So it's important to keep that in mind, especially given what your patient's kind of preferences are, right? I've had cases where young girls, especially they are type 1 diabetics, they wanted to lose weight, and so they end up kind of skimping on the insulin, and guess what? They end up in the hospital. They're hyperglycemic and they're DKA. So be aware of that. That can be a really sensitive subject, especially for some patients who weight is important to them. Okay. So anyway, drugs that can decrease the hypoglycemic effect of insulin. So these are things that can all make your insulin work less effectively. So some of these we've mentioned before. Some of these are going to have more or less kind of clinical implications. Certainly things like oral contraceptives may not normally think of as increasing blood glucose, but that could be a possibility. Corticosteroids is probably going to be a more obvious one. We already mentioned corticosteroids previously and how that causes hyperglycemia. And any kind of like catecholamines, because if you think about epinephrine, that stimulates your fight or flight response, right? When you have catecholamines affecting your liver, what does the liver want to do? Make sugar, right? Because you got to run from a bear, fight or flight response, right? So I need more sugar to have energy, right? So anything kind of pro-adrenergic can increase blood glucose. So just be aware, lots of different things can be affecting this. It's important to not just say, let's give you more insulin. It's got to look at what else is going on with the patient, make sure they don't have drugs that are interacting. There's not other things that are more at fault here. Okay. Yes.
Do Tylenols or paracetamol affect?
Not that I know of. I've not seen that. If there's anything out there, I've not seen it.
Okay.
Yeah. If you find something, though, let me know. Yeah. Anything that can increase the hypoglycemic effect or make you more prone to hypoglycemia. So alcohol can do this. This can be especially problematic with type 1 diabetics I've seen who like to go to college and then guess what? They like to drink. And this can be problematic, right? Because it can lead to like an alcoholic ketoacidosis and all kinds of other problems. So they can have big problems with kind of glucose and hypoglycemia developing there. Anything blocking the adrenergic receptors, right? So the exact opposite of what we mentioned last slide. Beta blockers can do this as well. So that can be another reason for hypoglycemia. Do you guys know what else beta blockers do to someone who's hypoglycemic? What are kind of the would lower the blood pressure? What does a person look like when they're hypoglycemic?
Cool, pale, diaphoretic.
They're cool, pale, diaphoretic. They're a little shaky, right? Beta blockers can block a lot of those responses, right? Because you're blocking the adrenergic upregulation, so it blocks the tremors. You may not be sweating as much. It can mask the signs of hypoglycemia, so they may go for longer, not realizing they're hypoglycemic until they kind of crash, right? So be careful with beta blockers and these diabetic patients especially. Okay. So finish up with insulin, then I'll let you guys go. So when do we use insulin for patients? So anyone diagnosed with type 1 diabetes, because they're not producing any of their own, right? So normally we'll end up finding a lot of these kids due to things like DKA. So you have like a new onset diabetic who comes in with DKA. That's a relatively common finding, at least for me, from the emergency department standpoint. Those patients all get put on usually insulin drips and then get converted over to subcutaneous insulin. Pregnant ladies, we mentioned, we don't like to give drugs to pregnant ladies, but insulin is, human insulin is a natural product, so to speak. So that one is going to be preferred for most of your pregnant patients who really have severe hyperglycemia. And then type 2 diabetics who are not being controlled with diet, lifestyle modifications, and oral meds alone, they end up getting transitioned to insulin as well. So again, usually you'll see type 1 diabetics being managed by insulin alone. Type 2 diabetics may have other anti-diabetic meds on board in addition to insulin. So you may see that combination there for those patients. Obviously, they come with DKA. We would go ahead and treat them with insulin because they're dealing with a severe lack of insulin. So we'll do that. And there's also kind of this hyperglycemic, hyperosmolar, non-ketotic syndrome. That's going to be more for your type 2 diabetics who have really, really severe hyperglycemia. These are patients who can have glucoses like in the thousands kind of range, right? So those can be very, very sick patients. And then hyperkalemia is another case where we might use insulin as well. You guys know why we might use this for hyperkalemia? Drives it into the cell. So just like it drives amino acids, it drives carbohydrates and all kinds of other stuff into the cell. Insulin can force potassium into the cell as well. So that's one thing we'll actually use for hyperkalemia. Okay, so I'm going to cut it there. I will go ahead and record the rest of this and post it up online, and then we'll do a review next week. You guys have any questions? All right, I will see you next time.